Well, good afternoon, and we're here today. We wanted to have a conversation about access and discrimination in healthcare, especially in 2020, but of course, we've been having problems with access and discrimination in healthcare for many years. And so we have with us today Anthony Feliciano from the Commission on the Public Health System and Seongeun from New York Immigration Coalition, and Chun, I'm sorry. We wanted to have a conversation about how discrimination in the healthcare setting affects people with disabilities, people of color. We can even see sometimes how it affects women or LGBTQI people, and how that can actually result in a delay in care. And what was really interesting, we wanted to have this conversation. We set it up at the beginning of September, but this is September 29th, and just today, reporting was done on research that was put in the Lancet, which shows that people have been talking about during this COVID-19 situation, why have people of color experienced, more hospitalizations, more death, and more diagnosis? And they've often looked at, oh, well, people live closer together, they work in occupations where they can't stay at home and they have to be, they're in essential occupations. And this new study that just is being reported on that was in the Lancet today also talked about delays in care being a reason for these higher numbers. And they showed that people of color are more likely to delay care, that from the onset of symptoms, white people went to the hospital within 3 days. Hispanics, and that's how they characterized it, went to the hospital within 5 days of onset of symptoms. Black people took up to 7 days to go to the hospital, and that might be one of the reasons why we're seeing more deaths and more serious problems with COVID. And of course, people with disabilities also have often delayed care because of an experience of discrimination in the healthcare setting. And so do LGBTQ people and women. Any kind of discrimination that you might experience might result in a delay in care. And in the COVID situation, this is one of the consequences. So anyway, I just wanted to start from the beginning, talking about what kinds of discrimination people do experience in the healthcare setting. And who'd ever like to address that first? Go right ahead, Anthony or Son, whoever wants to go.
Seongeun, you want to take, because I think we both work together on a lot of these issues.
Okay.
And we can both discuss how we came together on a campaign around some of these things too.
Oh, good.
Yeah, I think before so Anthony and I collaborated along with a few other partners on this letter that we'll get into. I think the outcome of the study from Lancet, I haven't read it in detail, but in some ways it is not surprising, because I think it sort of not alludes to, but it does, is really about social determinants of health, like such as, race, physical environment, racism that people face, like all those things also that are outside of the hospital play within the hospital. And so, and I think there was recently a study also, it may not have been a study, but more of an article that talked about Black patients who were treated by a Black physician receive better health outcomes than being treated by a white physician. So, and I think in particular to immigrants, there are many things that play a factor. Language barriers, one of them, public charge, not having access to care on a regular basis, and then just the overall structure of how there's, economic and racial inequalities that really play into what a lot of the Lancet study alludes to. So I just wanted to sort of acknowledge that, so that this is a really important study that sort of confirms a lot of the things that we've known all along in the healthcare system. And I hope that within, these issues persisted even before COVID. And I hope that this opportunity that we have now because of COVID, that we can really make some structural changes that can really alter and provide better health, health outcomes and access to care for, everyone, regardless of their status. Anthony, do you want to go a little more into the letter that we worked on together?
Yeah, I just want to add a little bit more. I think we always talk about conditions that keep people sick or keep people well, right? We're all calling them social determinants of health. But I think there are political determinants of health too, that justify years of racism and discrimination through policy, through negating community input, not engaging groups, to experimentation on communities in terms of the Black community and the brown communities and what they face in many years of their exposure to the healthcare system, good in ways that they've been experimented on, they have been treated such unfairly. So you have this huge mistrust, but also this really legitimate fear that gets passed on generation to generation. Some of it is part of our shared trauma in terms of Black and brown communities, but it is essential to address those things and not to just make them a professional academic exercise in terms of just making improvements to healthcare. We're talking about major amount of systems beyond just healthcare. Everything that we face very differential exposures in our white counterparts when it comes to healthcare, but in many other systems, not just any other system, housing and all that, anything that's keeping us well, keeping us to prosper and do well. So I think we need to address it very systemically. There's a lot of structural issues. You have a lot of corresponding implications of things. I feel like stigmatization has increased even in the Asian Pacific Islander community. And then you imagine the identities, because we're not monolithic, right? Black and brown communities are not monolithic. Within Black communities, we have transgender, we have people with disabilities, we have different identities. So imagine how more complicated it is. And it's not just it is important. It's understanding why you believe Black Lives Matter, why the movement has moved strongly. It wasn't just to address police brutality, and people have a misnomer about that. It was about the livelihood and the lives of Black people and what they have been exposed and what they've dealt with for centuries, and that's why these things matter. And so when you look at healthcare, you have to change those structural issues. It is no longer asking for incremental. It is about a real anti-racist health system. What does that mean for communities? And so Siegfried and I had with other groups and had their sign-ons, and we had CIDNY and other sign-on, was around how you protect marginalized communities during the time of COVID. And there was a lot of areas, a lot of determinants that we wanted to address. And the major ones were around testing and tracing, because we really knew already discriminating racist policies, and we really knew that there was going to be some gaps that we needed to address that area. And then address how we expose our communities into the healthcare setting, how they reach out to doctors. I have a friend who made something ring in my mind about if a white person came in with dermatological skin reaction, somewhat during COVID, because they had COVID, it looked very different on a Black person, particularly on their feet. And so all these pictures that doctors were given was always of white patients. Well, how does the disease and something like COVID manifest in Black and brown communities? And so you have to look at how that is, and then think about what is causing us in terms of those conditions. It is not just, I'm very careful of talking about communities in such a way that's a deficit, that it was overcrowding. Yes, it's overcrowding, but why are we in overcrowding? It's not the overcrowding itself. Many communities, immigrant communities, live together. It has nothing to do with overcrowding. It had to do with the conditions of that overcrowding, where they're living, the insecure housing, the things that were going on, which are disproportionately impacting Black and brown communities. So I think when we look at it, it's about those differential exposures. What do we need to do to make real change in a healthcare setting? And think beyond what it means in terms of how communities have taken care of themselves for so long, even in this very racist system. And how can we incorporate some more holistic views of healing in our communities? These are critical issues that we've been addressing for so long, but it's not an academic exercise in trying to do it. It's a real justice issue.
Yeah, well, I will say that people with disabilities also have always, the disability rights movement always looked also at discrimination from a systemic point of view, with the idea that that there was nothing wrong with the person with the disability, but that there was something wrong with the system that they had to interact with that wasn't able to accommodate their disability. And I think it's the same for people of color, that they're dealing with a system that's racist, and that is not, in some ways, accommodate, is not treating people as individuals, and is stereotyping and marginalizing and valuing them less. And I think people with disabilities definitely experience that quite a bit also, as of being devalued, even to the point where what we have in healthcare is we have this thing called crisis standards of care, which are things that are to be implemented when we're in a crisis, like COVID, for example, is a crisis. And the crisis standards of care that people with disabilities were expecting to possibly experience were a shortage of ventilators. And what was the process by which they were going to ration care? And they were going to determine that a person with a disability had a less valuable life. They have ways of like measuring the value of a person. And I think people of color, other people who are not white men, have the value of their life measured as less. And so that's been a fight that we all have to take on.
But to me, Heidi, it translates to something even deep about all the support systems or services that marginalized communities rely on, Black and Brown communities rely on. This includes people with disabilities, gets attacked. So that in itself is a racist also attack and a discriminatory attack, because if they don't value us, they do not value the services that we rely on. They break perception and description, they're inferior. You have that with the public hospitals all the time. They're inferior to the private hospitals. Why? Because underserved communities use it the most. No, it's decisions made to underfund anything that Black and Brown communities rely on, because somehow we need to fight to deserve it. That we have to, and all these toxic narratives for years that are gone around every system, and allow us to justify, or if we change those things, it allows us to justify new policies and new changes in healthcare, including the fights that people have been having now. Shared sacrifice with taxing the rich, with creating some equitable lenses to all the policies that are when they're addressing hospitals and what they serve. All those things happen, but we have to deal with these toxic narratives that are constantly about what the system, how efficient it is, and what Black and Brown people mean in society.
Seongeun, what are there might be some additional barriers that immigrants face when trying to get coverage or trying to get health care. Could you talk about those a little bit?
Yeah, I mean, I think some of it is because of sort of the ongoing attacks at the federal government on immigrants, right? And so there's fear of going to, wanting to seek care, but delaying care because of fear, because of public charge role. There's also lack of, like language access. Although I think, New York City Health and Hospital has been, they're good about providing interpretation. There's that discomfort there as well. And then I do think that some of it, and then, ultimately it's also about access to care. Many immigrants and many of those who are essential workers who really kept our city running and continues to keep our city running during this pandemic don't have access to care because of their immigration status. And so, if you don't have access to care, if you don't have a regular source of healthcare, then you wait till there is a catastrophic incident. And if all you have is emergency Medicare, it's better than nothing, but it's not regular care. It's only to cover that emergency setting. So I think the system denying them care despite all the taxes, commitment through the work that that many immigrants, essential workers, continue to devote to keep our city and us safe, for those of us who have the luxury to stay and work from home, that needs to completely change. And there are other, barriers. I think, just having a physician who looks like you really does matter. My parents have been living in this country for over 40 years, and they're college graduates, but they still want to see a Korean physician. They do not want to see a white physician. It's more than the language barrier. It's the understanding of culture. It's the understanding of respect. It's about cultural competency as well. And so I think those are some of the factors that make it challenging for immigrants to seek care when they need it. But we really encourage it through our work. But I think it's really tough during these times.
Yeah. So I think I just wanted to say a little bit more about what people with disabilities experience. Actually, people with disabilities are more likely to have health coverage. Now, we always talk about the uninsured. For example, I think in this study today, it said that 45% of immigrants were uninsured, which is like a high number to me, and that only 8% of white people were. But people with disabilities are more likely to be insured, but they're more likely to have public coverage and not have private coverage. So that means they're going to be having Medicare and Medicaid, which is, a different kind of coverage. Especially Medicaid now, we have all these health plans. Now, a few years back, we did a bunch of focus groups. The Immigration Coalition was involved, and also Raising Women's Voices for the Healthcare We Need. And we really kind of looked at health plan networks, a limited network of providers that you're allowed to go to. And we did focus groups with a variety of people, about how they found their network, and did they find that there were a sufficient number of providers that could meet their needs by being, disability competent, knowing how to treat people that are LGBTQ. Did they have a sufficient number of women, because women often prefer to see women providers, just like, a Korean might prefer to see a Korean provider. And people had a lot of difficulty, especially, they had a difficulty in even finding specialists. And what we found was that they would just throw up their hands and go without care, or they would delay care, which is this study today is showing that people delay care because they aren't finding providers that know how to accommodate them. People with disabilities often have to train their provider. And so, because you can have a variety of disabilities. You can have a vision impairment, a hearing impairment. I was just reading recently about, this child who had a hearing impairment, and the providers kept trying to explain what they were doing, and the mother kept saying he's not responding because he doesn't hear you. People often think about, oh, well, do they have, wheelchairs and wide enough doorways? But there's all kinds of other ways that people need to be accommodated. They may not, they may have a cognitive impairment. So, so often it's not like a blanket thing about equality. It's a negotiation under the Americans with Disabilities Act to negotiate with your provider about what is a specific kind of accommodation that you need. So of course that takes a lot of time. And then when you have a disruption in your provider network because your coverage gets changed, or you become ineligible and you lose your coverage, you have to get it back again, and then you have to train another set of providers. It just becomes really, really difficult. And I think it becomes difficult for all of us. A provider relationship, ideally, should be a long-term relationship. There shouldn't be disruptions in care because of disruptions in networks or disruptions in coverage. So that's, you know, that's just another barrier that all of us, I think, encounter. So like during the COVID situation, we have, I wanted to talk specifically about what people encountered trying to find testing or trying to get care in their neighborhoods and in their communities. You know, did you have any stories of people that had difficulty with this?
Let's think about all the things that happened, particularly around April, when testing seemed to be so-called about to ramp up, and tracing. There are maps that we saw personally from the Department of Health and others that showed testing sites where they were located. Obviously, they were predominantly health and hospitals and a few other private facilities. You saw the Upper East Side of Manhattan, other parts of Manhattan, with huge amount of testing sites, which wasn't surprising to me because there was a large amount of hospitals in the area. But you saw Rockaways, even parts of Elmhurst and other, with very minimum amount of testing sites, which showed me the disproportionality issue, and even in the distribution of testing sites. Then you had accessibility issues in terms of the hours those testing sites were open, right? They weren't open doing what they so-called calling all communities essential workers, right? I have a issue with essential worker because it seems like a convenient word to say temporarily when they're valuable all the time. But those hours were staggered. That's why Seongeun and I and Chinese Planning Council and a few others wrote a letter, because we saw some accessibility issues in testing very early on. Has it improved? Of course, but you still have issues in the Rockaways. You've seen outbreaks in Sunset Park. Some of that has to do with the availability of the testing site in terms of the hours, the confusion people are having around it because things weren't translated and interpreted well to communities, immigrant communities, in terms of how the accessibility would look like and what the difference between antibody and regular testing. And, you know, if you have someone who's working at odd hours because of from a grocery store and on, they don't have time to go there. Or if you don't have the proper childcare, there's so many barriers, particularly economic ones that people were having. So those have to be addressed. And then we saw issues in the tracing. While they just said that tracing has gotten better, when they first started off, they only got to 70%. They were supposed to reach a 90% in terms of tracing. They just recently reached that goal, but there's still problems within it. We don't know what's the language and competencies of all the tracers. We don't know what the competency of the tracers. We don't know if people are understanding every part of it, because now with the so-called surge that can come up again, people are getting more lax, so we have to increase more the education. We have issues with parts about New Yorkers who are more privileged than others, right? And so not respecting that part. And then there's a blame game, you know? When originally everyone was doing tracing, people were feeling fearful. Are they gonna be put in jail because they didn't do something, or are they gonna get caught? These are legitimate fears for centuries because of the way quarantine has worked in communities of color, particularly immigrant communities. And although we weren't in quarantine, we were in sheltering in place, which is a slight difference. For communities like Latino communities and Asian and other communities, that makes no difference to us. We don't know the difference between shelter in place and quarantine. We see it as the same, and so we are fearful and we act according to that. So, you know, there's several things, you know, we can go on and on. I think for us it's been, we can't go back to normal. We want to go back to normal in terms of engaging with people and having kind gestures and all that. But we can't go back to the same normal because it was the status quo. That is what caused so many deaths. While people died from COVID, it was the issue of racism that made it worse. And then you compound it when you don't implement and create protocols and operationalize them in communities in terms of their access to care. So many communities have to take care of themselves and find ways to take care of themselves. So we need to learn from all that.
Yeah, we saw a lot of the mutual aid that when government didn't step up, that that we had these mutual aid organizations that popped up all over the place, much like, you know, during Hurricane Sandy, we had Occupy Sandy, which was sort of a mutual aid kind of situation. I did want to just see if how people experienced, you know, during the COVID, you know, lockdown, when people weren't going to healthcare settings for their healthcare, and they were really promoting telehealth. And you know, especially the providers, you know, they felt that this is what kept them, you know, alive as in from going bankrupt, because they were able to use telehealth. But for people that were needing to use it, you know, I wondered if you had any people that you talked to that had experiences with telehealth and how that worked out for them. Was it good or bad? Oh, Seongeun is muted. Yeah.
I think it's not all good or bad, like many things. I think it, you know, what I've heard through from some of our partners who work directly with immigrant communities here in New York City, and even just for my parents, it seemed like telemedicine was really, it opened some opportunities to see physicians, you know, given that many of the appointments in person were not feasible. But in terms of access to technology, to Wi-Fi, all, you know, like I think that really was a challenge for many of the families that we know. But we have, you know, through the work of many of our partners. So for example, Voces Latinas, they are one of our community-based organization partners out in Queens. They were really instrumental in connecting and supporting immigrant communities in Queens, who are really one of the hardest hit immigrant communities during the height of COVID, to link them to care via telemedicine by supporting them with like a lot of the work that was required before logging on to see a provider, meaning like setting them up with technology, training them how to use video or its telephone, and then perhaps also providing them space to where Wi-Fi was available. So I think like technologically there were some challenges, and I think in terms of uptake of telemedicine, I think, you know, the impact of it varied among different ages. I think like younger folks, immigrant folks who are more tech savvy, who have the ease of smartphone, that, you know, that was a good opportunity for them to connect and see a provider. Whereas, you know, for older folks like my parents who are in their 70s, who can just basically, you know, who don't text on a regular basis or have a smartphone, that created a bigger challenge, and that they needed a lot more support. So I think you know, telehealth, it really provided a great avenue to see providers during the time when it wasn't possible. But I think it required a lot of critical support from community-based organizations that have been working all along this time and who were still out in the community, you know, with proper social distancing. And so I think those community-based organizations in the communities who had a trusted relationship with you know, many of our immigrant families really played a critical role in connecting them to appropriate telemedicine, you know, experience.
You know, I think also we have to think about that there was some sense of security for people just not being in a clinic and all that, because they felt safer, right, through the telemedicine. That's a good thing. But the issues you may have is platforms that work for people with disabilities in a proper way, right, at all levels. What about people that need therapists in mental health? Like I know a range of many art therapists who now have to do telehealth through a screen with children. That's not easy to do. So that includes my wife. My wife is an art therapist. That's why I say that, because I saw what she had to go through. And how do you make people feel secure that there's confidentiality and there's a private setting, right? Because many like therapists had to work from home. So you see all those dynamics. I think we have an opportunity to strengthen it. What I'm worried about is the healthcare industry, hospitals, particularly, obviously, going too far with it, and getting away from actually taking care of people in a way that is more traditional. Because my concern is putting a lot of funding around there and not looking at strengthening other parts of the system around accessibility and around other factors. So that's what I've been a little bit worried about, because it seemed like a ching-ching moment for a lot of hospitals to get money for now. And so we need to be careful with what that means in terms of balancing out taking care of communities with finding platforms and how you take care of communities.
Yeah, I think, they're talking about trying, the CMS loosened up a lot of the regulations around telehealth or telemedicine. And they said that you didn't have to use a video. The site could be your home. It wouldn't have to be another, medical provider's office. It could be telephone rather than video. And then also they were allowing sort of less secure kind of, in terms of confidentiality, methods of communication. I know, especially with mental health, and if you, say you do live you do have, like, everybody's home now, they're not working and they're not going to school. So where would you have a setting where you could be by yourself to communicate with a mental health provider and not have, other family members around? Certainly we work with a lot of people that are in nursing homes who, they don't want the nursing home providers to be, to hear their conversation. And of course, there are adolescents who maybe they need to get contraception, or they're trying to get some kind of reproductive health care or even mental health care, where they don't want other members of their family knowing about what, they would just like a more confidential and private setting. So, I really hope that, I think what we're seeing is the providers are like, especially they got reimbursed at the same rate as an office visit, so they're like, oh, we could see a lot more people and make, the same amount of money as if we saw less people through office visits. And so they seem to really want to continue this. And I think we have to make sure that we comment on any regulations that are coming out about continuing this, and try to see if we could maybe restore, the good things about telehealth, let's keep them, but to not forget that that if healthcare is really about a relationship with a healthcare provider, an in-person relationship probably is going to work better. It's certainly going to work better for people with disabilities that have communication, disabilities that involve communication. Really an in-person situation is probably going to be better.
There are two comments from Claire Londono from Urban Health. I can go ahead and read them. She said,
yeah, I looked at the questions. All right.
Yeah, it says our community. Yeah, it says our community does not have the technology to participate in a virtual telemedicine when they're using the phone, internet for the kids to do the homework. For other kind of community could be easy, but not for our community. She also said telemedicine is sharing your information, conditions, and confidentiality with others. It is not for the community with difficult conditions, sharing a room with a lot of people, and now worse because they have not, they don't have money to pay the rent. And then we have one from Leslie Folt Morrison. While the conversation seems centered on needed policy and advocacy, I would like to suggest CIDNY possibly collaborate with OATS.org, Older Adult Technology Services, which teaches tech to seniors and might help people learn how to use telehealth.
There's also the SAGE group, and there's a few, over time, there's been some funding by Gail Brewer for some technology things around seniors too and people with disabilities, but the problem is they're sporadic. All resources that we get for communities seem to be to just a moment of time, instead of thinking about sustainability, thinking about decision-making, thinking about really what do we mean to invest in communities and their access to care, but their care in general, right? So all this idea of mutual aid and all that. And so we really need to think about policy in many ways, but we also need to highlight major changes in terms of existing policies and regulations that are not helping us at all. They're really just justifying racist decision making.
So, you know, what do providers and what do the healthcare system really need to do to overcome mistrust that's been created by discriminatory treatment or existing barriers, you know, for the future, so that people can access treatment in a you know, in a more positive way? I mean, I guess, you know, one thing that we always talk about, you know, data and finding out, just asking finding out, you know, collecting the data, but also using it in the instant situation. So, you know, just even asking the question, you know, what language do you speak? Not approaching everybody as, you know, plain vanilla person, and asking the question, you know, what do you have any disabilities that need to be accommodated? What, you know, what is your preferred language? You know, maybe, and not to assume one way or the other, you know, but to just find out, to ask the question, and to sort of maybe do screening would be the first thing. But, you know, what else should providers be doing to, you know, to try to create a more trusting provider relationship? And a better system too.
You know, I've been going back and forth for so many years about incremental change versus really broad stroke, you know, hard-hitting change. And I'm being a little tired of incremental change on some of these things. I don't think it's enough where you will see a lot of hospitals and say, well, we'll hire more people of that representative of your communities, right? And that's great. But there is still issues and biases and prejudice within our own communities when serving communities and within each other, right? Latinos may have a view of Asian Pacific Islanders and vice versa, and Black. And we have those things. So there needs to be a lot more better training of providers. And some of these boards and of the medical schools who are mostly pale and male, and most of the boardrooms of hospitals don't represent us either. So there's the way decisions are being made. So those things have to be changed. Funding streams need to across the board to support systems that are supporting communities of color, Black and brown communities. And then you also have to have a better engagement of frontline communities. You know, some of us had to deal with transformation, so-called reforms for many years in healthcare, however they want to define it. But it's always centered on the hospitals having control and thinking it through, instead of the community-based groups. And I'm going to say community-based organizations and frontline because they differentiate in some ways. And so we need a better, not an engagement, we need literally a leadership process where there's real health planning, where communities have a decision in the fate of their own health and how resources are being allocated. We need some type of new paradigm of how that moves forward. And then we can add all these different incremental pieces to it that we want. More representation in the medical field, but not just the medical field, all fields. You can, I hear all the time with my wife, they'll say, well, you're the first Mexican American that I ever met as a mental health therapist. That's my psychiatrist. You know, they don't know. They get shocked. And she works with a lot of immigrants, and they have their own perception where some of our people, what type of jobs we have. And so there's going to be a lot of education, a lot of cultural competency training seems to be so academic that it lost its sense of what really is about. I don't think several hours teaching competency is going to help any medical professional. I think this has to be embedded in the policies, embedded in constant training, has to be embedded in the interactions and how they work all together. So that's one area. And then, like I said before, we need more leaders of color in decision-making roles who have an understanding of other people of color, right? Not siloed in themselves. And I say that because there's always a decision about monolithic. Me as a Puerto Rican man needs to understand what a Colombian or Ecuadorian goes through, not just as a Puerto Rican man. You know, needs to understand what a Puerto Rican woman goes through. We need to have a little bit better understanding of our identities within our diversity to respect and figure out policies that are going to support real system change. And that's going to take some time. A lot of it has to do with changing the way funding goes to things. And sometimes it has to be, I don't believe in being punitive, but I do believe our healthcare system needs to feel some consequences of their discrimination. And what does that mean in terms of regulatory action? What does that mean to remove funding? What does that mean to put caps on CEO salaries because they make so much money and it's all about greed, not about care? All those things need to be put in place, and not in an incremental way. It needs to be a robust package.
I just think adding a little bit to what Anthony said, I mean, yes, there are things that providers can do on an individual level, you know, with being more providing care that's more patient-centered, whether that is via, you know, language, being, you know, respectful, humble, listening to the patients. But I do think the greater issue lies in the structural change. That is what is going to force the system to be changed. And right now, as Anthony mentioned, the leadership is heavily occupied by, you know, Caucasian males. And I think there needs to be not only more representation, but training even starting early on in medical school, and maybe perhaps in our education system. You know, for example, like New York City, our school system is the most, you know, segregated, one of the most segregated school systems in the country. You know, and so I think it needs to start early as part of our education system from when we are young. You know, there are studies that indicate that like kids from the age of two or even, I mean, I don't want to quote the exact age, but from an early on, kids can see a difference in color. And so I think it really needs to start earlier on, and then just, you know, continue that awareness. But ultimately, there really needs to be a shift at the structural level in leadership, and where the decisions are being made and where the money is, you know, it's ultimately so much of it is about generating revenue for the hospitals. And so perhaps changing that to, you know, patient satisfaction, health outcomes. I mean, US is, we spend so much money on healthcare, but we have one of the most poorest health outcomes compared to any other industrialized country. So we need to examine that. We're clearly doing something wrong. So yeah.
Yeah, when I first started getting involved in this whole cost of healthcare and bending the cost curve, and, you know, when they were looking at how expensive our healthcare is, you know, after they thought we had solved the coverage situation, which of course for immigrants we did not. You know, the way to go up against the cost is to try to value quality, but then how you measure it. And then there's this whole quality measurement. There's like 600 quality measures at least. And there's a whole industry of quality measurement, and it's very hard to understand. And, you know, even when I try, for example, our folks have a lot of people on Medicare, because, you know, it's not just for people over 65, it's for people who have acquired a disability or been born with a disability. And I told them, you know, there's a 5-star rating system in Medicare, and with our Consumer Action Network, I told them how that 5-star rating system has come about, and they're like, those things that they're measuring have nothing to do with me, you know. And, so it's very, you know, it's just mind-boggling to try to counter the whole cost thing with a quality measurement thing. But that seems to be, as long as we have a system that really is looking at the bottom line, that always seems to be the only way to do it. So when we have all this managed care, where we've taken our public health, our public coverage situations and given it to managed care companies, like whenever they find that the managed care companies aren't really doing a very good job, they try to figure out, well, how can we incentivize them by withholding some of their payment unless they do X, or giving them a bonus if they improve their quality score that we measure in this particular way. So, and you just often, a lot of times, I don't think that our constituencies are at the table. So in the disability rights movement, they always say nothing about us without us. And I think quite often it has been without us. And as we've tried to enter these spaces, they're so mind-boggling that you can't really even figure out, it really needs to, in a lot of ways, it probably needs to be almost dismantled and built up again, from a different perspective. Because the way we're measuring outcomes now and the way we're measuring quality now is really not working. And the outcomes that we have, like you said, are really bad. If we were, when you look at across nations, if we were to eliminate health disparities based on race, ethnicity, disability, gender, that would really improve our quality scores. I mean, just that would bring us up like so far that, we wouldn't look like the outlier among nations. And so that could, I've been trying to say this for many years now, that why don't we do this? And, we could really improve, you could really improve your overall quality if you would address the discrimination.
That goes into having, I've gotten away from having safe spaces on these issues, because I can't guarantee that I'm going to have a safe space about these very complicated, some harsh things that are going on. I think about a brave space. That doesn't mean disinvesting in areas that we don't need to invest no more and reinvesting in other places when it comes to healthcare. That's a big paradigm shift, and we have to fight for that. That means that we can't continue putting fresh water in a contaminated well. So when something's not working, you bring the managed care with it. It was already a contaminated well. So there's what Seongeun is saying also is those structural changes. If those don't happen, we keep repeating that stuff. We just create new industries to solve solutions and create new hierarchies and so on. And so we continue all these isms that we're all facing within, at least in the healthcare system. That's similar to all other systems too, but becomes a problem. Like, to be honest, if we had defunded the police properly, at least in New York, there would be money invested in areas about the well-being of our communities, right? And we can have decisions how that looks like. There are places that we don't need. They are institutions, and they're built from the ground up from a racist standpoint from the get-go. And so you got to fully dismantle it, revamp it. Doesn't mean that all of a sudden it's going to, everything changes quickly, but we're going to need to do that. We're going to need to do that because everything that our Black and Brown communities are exposed to is important. When you have the argument about shared sacrifice and, taxing the rich, like, we need to have narratives that say Black and Brown communities create wealth here. That's who they really create the wealth. There's a lot of narrative building that we need to do. Some of it is going to have to address the biases and prejudices that even Black and Brown communities are going through, but it's definitely going to have to address the racism and the privilege that our white counterparts have had, and how that plays out. So that's what I mean by brave space. We need to be enough to say that. And another part of it is no longer Black and Brown communities need to explain themselves about why they matter and why this is so. It's our white counterparts need to do their own education and work it out, and we can ask questions of each other and figure that out. And so we can move forward. And I'm sorry to be blunt to that, but we need to get to that level of real conversations. And some of us, even from Black, are nervous to say these things too, because we have great white allies and great white friends. That's just, those things are also conflicting in our communities too. And when as a Latino man, I had to deal with constantly just the idea of Black Lives Matter, even in Latinos, because of our color of our skin too, light skin. So those things need to be addressed. And while it may not be about healthcare, it translates into the decisions, it translates into the policy, and it translates into how we deliver care to people. So we need to really get into those things. And then we're gonna have to push back and have government take more onus around the aiding of communities, right? I'm not taking any partisan, but Republican and Democrat both talk about they don't care about big government. They both care about big government. Democrats care about big government in a different way, and Republicans do. But that narrative is such false narrative. Both sides want big government. One in terms of getting control and having more resources in a different way, and one to give resources in one way. So these narratives need to be educating in our communities because they know what they're going through. So we have that bidirectional, but I really believe that there needs to be at every point of every regulation, every policy, equity lens, something that guarantees in decision making, and it guarantees in resources, and it guarantees in the delivery of those things.
I just want to read a comment by Leslie here. It says, I think the pandemic exposed how many hospitals and doctors here in New York City approach the care they provide with a primary goal to make money. Our fee-for-service model has not worked well when people need to stay home to stay healthy and need preventive care and guidance to keep from getting COVID-19.
Yeah, they did. There has been some, writing on the idea that the value-based payment model in this situation really worked better than a fee-for-service model, where you're getting paid to take care of a person, not for the number of procedures or visits or whatever that you can deliver, especially when the system sort of got shut down for a little bit, so you weren't allowed to deliver. We had the hospital association. They have a huge ad campaign to try to tell people it's safe to come back and get procedures and visits so that they can continue to get their bottom line met. But if they were being paid to just take care of a person, it would be a different situation. So I'm glad, Seongeun, that you've been looking at the question and answer, because they don't pop out to me and I keep forgetting to look. Well, it looks like we have maybe about 5 more minutes. I don't know. I know my clock is a little fast, but do we have any other closing thoughts?
I just want to again re-emphasize the importance of collaboration and partnerships, community level, all of each other. That's always critically important. But also, you mentioned about fee-for-service and value-based care, right? We need to define those things very clearly from a community perspective, because it gets defined for us. It gets defined from opposite. And then you can put a value-based care system, which was trying to be done through district at a point. But if the wheels being driven by the same ones that justify and continue the racist work, then or policies in order to keep themselves in power or keep themselves getting the money, then we're going to continue. It doesn't matter what we do. And so, there's an importance about talking about what it means to have value, what it means to have it based, and then what else care. Because even district was a issue of cost only. It was only, and its name alone is an incentive payment program. It wasn't an incentive for people's program. There's a big difference there.
Yeah, and it was about reducing hospitalization and ER visits. It wasn't about providing holistic care to people. Especially people with disabilities may need to go to the hospital quite frequently. So, they're going to be people that, a value-based payment arrangement is not going to want those people because, maybe they have a condition that requires it.
And our primary care allies and FQACs and others, lookalikes and so on, face the same struggles as community-based care and others. We're similar in the fights, but we need to join a little bit more on these issues. Because anytime there's a new transformation, primary care is never addressed. It's so-called peripherally addressed. Even district wasn't even addressed. People were uninsured until advocates came together and fought to make sure uninsured was addressed, and that was in a minimum still. So it does take a lot of advocacy. But there are enough of us together that we have enough brilliance to make change.
Well, I think that's probably a good closing note then. So I want to thank you, Anthony, for joining. Anthony Feliciano is from the Commission on the Public Health System. and Seongeun is from the New York Immigration Coalition. And CIDNY is Center for Independence of the Disabled in New York. You know, we didn't really describe our organizations that well in the beginning, so maybe we should do that. CIDNY serves people from cross disabilities, so that's all types of disabilities: mobility, hearing, vision, cognitive. And our goal is to make sure that people can live independently in the community instead of being forced into institutions or like nursing homes, psychiatric facilities, whatever, that are not appropriate for that, to meet their needs. I don't know, Seongeun, you want to say what Immigration Coalition does?
Yeah, so New York Immigration Coalition is an umbrella organization composed of over 200 immigrant and refugee rights groups across New York State.
And Commission on the Public Health System is a lean and mean community organization that believes in coalition building to get things done, and with a lens around equity and community-centered approaches.
And I think we all work on healthcare from a perspective of we've known long before the social determinants of health got coined as a word that there's a lot more to health than health care. So all right, thanks for joining me today, and I guess we'll call it a wrap.
Thank you.
Thanks.
Thank you.